So again, hello and good morning, good afternoon, or good evening to everyone again. And thank you very much for, again, hanging out with us here at the iYouLead Hangout series. So this online session is set up by the members of the International Young Food and Nutrition Leaders to provide an online social and learning space where everyone can feel connected while enjoying meeting people from around the world and learning new things. So now we are on our second session, and allow me to introduce our moderator for today. Okay, so our moderator for today is Jolene Lee from Malaysia. Jolene is a nutritionist by profession with a Master of Degree in Community Nutrition from University Putra, Malaysia. She currently works as a sales nutritionist consultant for Healthify Me Malaysia, a startup company. Jolene is also passionate in creating simple, delicious, and healthy meals. You should follow her in Instagram because she posts a lot of delicious meals in her Instagram. So without further ado, I would like to turn over the space to Jolene.
Yep. Thank you, Jules. And hi, everyone. Hi, everyone. So again, my name is Jolene. To those who not really haven't heard about Jules' introduction. So my name is Jolene, and yeah, currently I'm working as a sales consultant in a startup company. And yep, I'm going to be the moderator of this session. So our session is entitled Tiny Little Things, Viruses, Micronutrients, and sorry, I blocked my site, and its effects human health. So in this session, we are going to have two speakers, one from UK, which is Shemaine, and another one is from Azi from Indonesia. So have a big round of applause. Welcome them.
Hey.
Virtual applause. Okay, we'll do virtual applause, okay? Right. So right now, before we start the session, let's set some basic reminders and also ground rules for all the listeners out there. We have 36 participants now. It's a very good number. Yeah, let's look at the share screen right now to understand some of the basic reminders. So the first one, the session will run about an hour. It will be an hour long session. So within this an hour long session, I hope you guys enjoy the session, and if you have any questions, do write it down, or you can send it through the chat function. All right. So the second point, speakers have 7 to 8 minutes to share their presentation. So Shemaine and Azi, you have 7 to 8 minutes to share your presentation. All right. So third point, listeners can ask during presentation by using Zoom chat function, which I just mentioned just now. Okay, after each presentation, 2 to 3 minutes will be allocated to answer the questions. So
I can't hear her.
Jolene, I think there's a problem with the microphone.
Jules, please unmute Jolene.
Did I? Hold on.
Yeah, unmute.
There you go. There you go. Can you?
Jolene's still on the mute.
Can you help me, Julie?
It's very strange. I tried to unmute her, but
well, now
it
she's
doesn't
frozen.
work. Yeah, maybe her connection has some problem.
Yeah. Maybe.
But she's frozen now.
Let me chat her.
Yeah, she is like freeze.
It's 7 minutes, just like iYouLead presentation. Huh?
Yes, this is a present. The presentation is the reminders. We have.
Yeah,
Okay.
I thought it's going to be more than that, but now it's back to 8 minutes.
Oh
And
my gosh.
she's out of the meeting. I think she's going to return.
Yeah,
You can take over for the moment.
technical difficulties.
Yeah.
Yeah.
So yeah, she was just going over the ground rules.
Yeah, okay. I'll just take this over now. So this is just the same ground rules that we had for the first session, but I understand there's a couple of people who were in the first session, so let me just repeat the ground rules. So I don't know where Jolene stopped, but let me just repeat from the first. What's happening? Okay, so the session will run for about an hour, hopefully, and without technical glitches, and the speakers will have 7 to 8 minutes to share their presentation. So the listeners can also ask questions during the presentation by using the Zoom chat function. And after each presentation, 2 to 3 minutes will be allotted to answer question. After that, the moderator will pick up a couple of questions sent by the listeners, and the listeners just to refrain from some background noise, we advise the listeners to mute their microphone. And a couple of minutes may be also allotted for the listeners to clarify some points or related concerns before the end of the session. And the session will be recorded, and we will share it online in our Twitter handle. Okay. Right. Let me just check if Julie is she here already? Not
She signed in again, but I couldn't see her mic. It seems like she was not connected to a microphone.
okay. Right. There's a problem with. Okay, so let me just take over whilst we are waiting for her. I hope that's okay. I hope
Yes,
that's
of
okay.
course.
All right. And right. So without further ado, let me introduce our first speaker for today. Well, Charmaine Brown is a public health practitioner with professional experience as a public health manager and strategy at a local government level, where she worked in managing long-term conditions and address health inequalities. She had lived and worked in London for more than 3 years and now currently living in New York City, the current epicenter of the COVID-19 pandemic in the United States. So she recently completed certificates in fighting COVID-19 with epidemiology and public health and humanitarian crisis by the Johns Hopkins University. Charmaine's presentation for this Hangout session will highlight the New York City strategy in responding to the COVID-19 pandemic. So I will stop sharing my slide now, Charmaine, so you can share your slide.
Okay, now we practiced this.
Yeah.
How do we share? How come it's not?
So
How do I share my screen?
You click the share screen at the bottom of the.
But it says stop video, mute.
There's another near the participants button.
Oh, share screen. Okay.
Yeah.
Desktop. Share. Okay, guys, can you see my screen?
Yes, with a very nice photo of an island. There you go.
Yes, how beautiful is that? So serene. Okay, play from the start. Okay. Thank you for that introduction, Jules. You make me sound very important. we're all working in making our communities healthier. So I will tell you what I'm doing here in the city now. As Jules mentioned, well, before I get started, just as a disclosure, this presentation is separate from my work with the local government, and I am not receiving any finances by giving this presentation. So just stating that. All of you must know at this point what COVID-19 is in the media. We hear what's going on, but then also for your knowledge, just to generally know that this virus is a respiratory virus that comes from a larger family of viruses that was first identified in the mid-1960s. It's a virus that's replicating in our airways and highly infectious. It was announced as a public health emergency of international concern, 30th of January, and an outbreak pandemic, the 11th of March. So as most of us are, we are staying home right now due to this virus. And in the United States, as of April 22nd, April 22nd, we had over 800,000 cases, total cases across the United States. And as of April 22nd, we had over 46,000 deaths. In the United States, we do have separate health departments. The Center for Disease Control is a national organization that oversees public health, national strategies and programs for the United States. But then within each state, we all have our own departments, public health departments. So for example, in New York, we have the New York State Public Health Department, and we also have the New York City Health Department. So far, as of April 22nd, we've had over 11,000 deaths in New York City. And New York City is comprised of 5 boroughs with 8 million people living within those 5 boroughs. We have Manhattan, Bronx, Brooklyn, Queens, and Staten Island. Those are the 5 boroughs. And within the New York City Health Department, we are confirming COVID-19 tests through confirmed laboratory tests, as well as liaising with local nursing homes and other care facilities like hospitals to identify our total count of confirmed cases and deaths due to COVID-19. So I put the sources there, as you can see. Rates by borough. So I mentioned in New York City, there are 5 boroughs. As you can see, the Bronx has the highest number, then Staten Island and Queens. This is our rate per 100,000 in each borough of confirmed COVID-19 cases. The Bronx is a high immigrant borough with mostly Latino populations. It's a very mixed borough of Caribbean, Latin American, African American, so very mixed. And we have to sort of look at what are the wider social determinants of health that could be causing the spread of the disease. A major issue in New York City, no matter which borough you're in, is overcrowded living. People are living in overcrowded apartments and spaces, and they're not able to isolate themselves. And so social isolation will be very difficult for someone who's living in an overcrowded space and very poor living conditions. So like many of us in our cities that we're currently in New York State, we're following certain guidances. We are practicing social distancing, we're wearing face masks in public to reduce community transmission. And as of now in New York, we're mandated to stay home until the 15th of May. And just looking at the more specific strategic approaches that New York City has taken, we are looking at a healthcare surge at the moment. So prior to this session starting, I mentioned that we have deployed nurses and other healthcare practitioners from other states to come to New York. So we are actually housing these nurses in hotels as they support our healthcare systems. We also have non-medical isolation hotel programs. So due to the overcrowded living conditions in the city, as well as the amount of vulnerable people who may be at risk of becoming infected of COVID-19, think about a household who has multi-generational family members living underneath the same roof. You're unable to socially isolate. So we have non-medical isolation hotel programs with over 100 hotels included, where people could stay in these hotels in New York City and quarantine. So this has been mandated by the mayor of New York City. I feel like this is a great program to tackle some of the issues that we have, along with other issues that tackle wider determinants of health. As you know, when the economy goes down, because right now we are looking at a crisis where people are losing their jobs. In the United States, there have been over 22 million people who filed for unemployment insurance, seeking job seekers assistance. And as you know, when the economy goes down, poverty and hunger increases. So we're looking at implementing different programs to alleviate those stresses in society right now. And one of those programs is around food access and distribution. So within the New York City school Department of Education system, so within the schooling system, we have a great program where schools are still open and they are distributing meals for students. So even though schools are closed until the end of the summer, it was actually announced by the mayor of New York City that children will not go back to school this summer. They are going to continue with online learning, but then we have to address hunger amongst these families. A lot of parents are losing their jobs. A lot of children rely on the school food. So we have schools that have stayed open from 9 o'clock in the morning till 1 p.m. distributing meals for these students. And they've actually opened it up and they said anyone can come. If you're in the community and you're hungry, you could come to this school and pick up food. And we also have access to testing. So NYCHA is a New York City housing authority where people are living in New York City apartment buildings and are receiving government financial assistance to help them pay their rent. We call this the New York City Housing Authority. It's shortened there for NYCHA, right here. And what the mayor has done, we are going to work with these buildings. Within these buildings, you can have hundreds, if not 1,000 people in one building. We have to increase access to testing. We are distributing free PPE, protective equipment, to these families that are living in the government assisted buildings. Helping them with food, as I stated, we have various food distribution programs helping them. We are going to run wellness checks, the city is. The mayor also announced that he will provide free internet access for certain communities in New York City, which is amazing. We are all online at this point, and we have to work with families who cannot afford not only their rent during this time, but how are they able to afford Wi-Fi? So we are addressing those things. And the city will also frequently clean. Sorry, there's a little typo there, frequent cleaning. But we would also clean these buildings. So the mayor is going to work with the NYCHA buildings and the communities that live there to ensure that they are protected. And that is really great. So that is the mayor of New York City there. Like I said, we have different distribution points for the 5 boroughs, and we have emergency funding for the city, specifically to alleviate food insecurity, which is really great that we're thinking about hungry families right now. And I am specifically supporting a program called Get Food NYC. This is a food distribution program specifically for vulnerable New Yorkers who cannot leave their homes. Think about someone who's diabetic in a wheelchair and they're self-isolating, and they really don't have access to the food distribution points that I mentioned earlier. They're unable to leave their homes because they're at risk of being infected by COVID-19. So we are, through this Get Food NYC program, we are actually distributing free boxes of food to your house. This is free food delivered to your house. We're providing 3 to 4 meals per person, even though that may increase. And this is being funded through emergency funds through the city. And how do you get the food? It is quite a straightforward process. As a New York City resident, all you have to do is create an online account, or you can call an information hotline if you don't have internet. Answer some qualifying questions. There are 5 to 6 questions that are asked to identify if you are a person that is vulnerable. And those questions are really asking you, do you have a social support network? Do you have anyone in your household that's able to go to the supermarket for you? If not, then you would be at risk. So you could qualify for this program then. You can then make a food selection. As of next week, which is absolutely great, we would have options for people to choose whether or not they need vegetarian meals, halal meals due to religious restrictions, kosher meals. We have a large Jewish population in New York City. We also have health dietary restrictions where people may be diabetic and they can't really eat sugary snacks like other people can. So we are taking into account the different needs of the population in New York. So as of next week, the types of foods that will be delivered to them will really be expanded through this selection criteria. And after you select your dietary restrictions, you give us the number in your household, and that will determine how many meals you will be provided. And we will then deliver that to your address. Now, let me go back. I would actually just state that it is not a perfect system. It was created 3 to 4 weeks ago. So we are literally building upon this system as we go. We are identifying the gaps, and we are identifying the challenges as well and trying to overcome those challenges. Right now, we have served over 2 million meals within 5 weeks, for about 4 to 5 weeks, which is absolutely amazing. But do we have it right? That is the thing. We are actually working on getting the food to these locations, trying to figure out how we deliver boxes of food to different apartment buildings. How can we get the food to someone who is in a wheelchair that doesn't have help? They don't have anyone to help them bring the food up from downstairs if they live in an apartment building. So trying to work out those different challenges is what we're doing right now. So we don't have all the answers, but what I can say, it is a great program which is alleviating hunger amongst the most vulnerable people in New York. At the moment, you can only order once, and you can only order every 2 days, every 2 to 3 days. So you can't put in the application, I want food every day for 5 weeks. No, so this is emergency food. This is a one-time application. You can apply again every few days. And so this is why we are going to work on providing food for up to 3 days. So instead of providing meals for a day, we'll provide you for emergency food for a few days, breakfast, lunch, dinner, and snacks. So that is the end. I don't know how I'm doing for time. Was that 7 or 8 minutes?
You're good with the time. Yeah.
How much time do I have left?
A couple of 2 minutes, like 2 minutes.
Okay. Yeah. So I don't know how I even get back to stop share. How do I stop share?
I can, let me do that. I think, where are you?
Okay, I stopped share.
Okay, there you go.
Okay,
Yeah.
yes, because I think it would be great for me to take questions. If you have, whether it's like questions specifically about the food distribution program or the other sort of emergency programs that we have running in the city that I mentioned, like the non-medical hotel program or the distribution of PPE and hand sanitizers and different things for the low-income families in New York. So please ask some questions.
I think Jolene is already in the meeting. So
Yeah.
welcome back, Jolene. And we're
Thank you.
very sorry that you've experienced a technical glitch.
Yeah.
And so I think Jolene would be very happy to moderate the questions from the audience. Yeah.
Okay.
Yeah. Yeah. So anyone from the floor has any questions for Charmaine? You can type, guys, if you are shy to voice out, you don't know how to express
I
in
can-
words. Yeah, sure, go
For
on.
me, okay.
Who is it?
Mela, too lazy to chat.
Oh, yes.
Yeah, for me, I was wondering, do you have any great job on having a specific food for those vulnerable, diabetics, etc. But what about for pregnant women, for breastfeeding women? Because here in the Philippines, in Manila in particular, hot issue here is the donation of infant formula, which is a violation of our milk code. So I was wondering how you are dealing with that in New York.
Well, we have the WIC program, which stands for Women, Infant, Children. And the WIC program, it does provide financial assistance as well as help for pregnant women with young children. Or you could just be a pregnant woman or be a mother of young children. And so that is a government assisted program that already exists. So right now, since we are in a crisis, what we're looking at is expanding pre-existing governmental programs. Along with WIC that's focused on women and children, you have, it's shortened for SNAP, but that means the Supplemental Nutrition Assistance Program. And really what the government does, they give you what it looks like as a credit card, and they upload money on that card. And that money can only be spent on food. It's not like a credit card where you could go to the shops and go shopping, but it's called an EBT card. They upload money and it can only be used to purchase food. Right now, this is such a great effort. Due to the pandemic crisis, since we need people to stay home, the government has allowed those vulnerable families to use that card and purchase food through Amazon and other online platforms, which is really great. So that is a new effort. So we're really looking at, one, implementing new emergency programs as well as expanding pre-existing programs.
Oh, that's great. Thank you.
Yeah.
Right.
Yeah.
Thank you, Mela. And I see that we have few questions coming to the chat. So I think let's go to the first question. We have Shenyi. Hi. Okay, we have Shenyi here. I think if not mistaken, he's from Malaysia. So he asked, or Shenyi, do you want to ask yourself?
Never mind, you can just read out my question.
Okay. So Shenyi asked, he would like to know more toward the non-medical isolation hotel program on how is the selection of suitable participant and how to execute it.
Okay, so let's think about operationally. From an operational standpoint, if I was looking to execute a program like that, one, I would seek partnerships with hotel management. This is key. So the managers of the hotels are your stakeholders. And so what you'd want to do is set up some sort of a short-term contract, whether it's for a month or two, let's say 3 months, where you have a sharing program. And these contracts, you would have to sort of identify the types of people that will be staying there and make sure that the hotel managers and the stakeholders within hotel management understand the criteria as well, and develop an application alongside those stakeholders, paper form as well as online application for participants. The non-medical isolation program is quite interesting because we really want to focus on the high vulnerable populations in New York. So I'll give you an example. Suppose you have a household of about 5 people two parents, two young children, and a grandparent. And you're living in a very small space. You're all living in an apartment, and it's a bit overcrowded. And we have a lot of overcrowded apartments in New York City. So that grandparent that should be isolating, who was unable to isolate, is at risk of being infected of COVID-19, can qualify to stay in this non-medical isolation program. But then we also have, sorry to stretch it out, we also have a case of people who are non-essential workers. So people who are every day working in the shops, they're driving the bus, they're driving the trains, they are at risk every day of being infected of COVID-19, and they are coming back home to their families. They're coming back to their communities, and they are infecting more people each day. So they are not only putting themselves at risk, but their own families and the community at risk. So therefore, you can qualify for the non-medical isolation program. You are not a nurse or a doctor, but you are an essential worker at risk. So that is a program you could qualify for. So I think that is great. And I think operationally, you just first have to think about which hotels you're going to form partnerships with and develop relationships with, and what community should you tackle. You know, from an operational standpoint, you'd have to look at the clusters, look at where the numbers exist in higher amounts, and you would want to work with hotels in the most high need areas.
Okay, thank you, Charmaine. So Shani,
Yes.
does that answer your question?
Yeah, I think I have another follow-up question where I think this initiative is actually kind of good, where you give accommodation where they isolate themselves from another high-risk population, which is from their house. But I'm just wondering, how long is the isolation period? Is it like 14 days, or, you know, like for how long? Yeah.
Yes, so they do recommend quarantining for 14 days. And the quarantine is based on the period of time in which you could develop symptoms. And so that's called the incubation period. The incubation period could be anywhere from 2 to 14 days, on average 5 to 6. So from being infected, it could take up to 14 days for you to show symptoms. And that is why they ask people to quarantine, self-quarantine for 14 days.
All right.
That,
okay.
Yeah.
Okay, that answers my question. Thank you.
Great.
Okay, we have a few questions come in again, and I found that a few of them, they actually addressing the same question, which is they talk about the food distribution program. So maybe I missed some of the information because I came in late, but they want to make sure when you distributing the food, how can you make sure the food is, you know, how's the hygiene of the food, and then how can you, another question about the food distribution is that how can you cater different kind of food to different health conditions at this moment?
Okay, so so just to clarify that these drivers that are distributing the food are not working for free. They are receiving financial compensation for their work. The drivers are not volunteers. So this is a fully operational system where people are being financially supported. I'm just making that clear. So this is emergency funds through New York City. So just stating that. Who prepares the meals? That's a great question. In the city, we are working with 10 to 12 large food distribution companies. These are food distribution companies that would typically supply food to supermarkets or schools, universities. So thinking along those lines, so those mass food production agencies. And so we're working with them to develop these meal boxes for families. And how hygienic is the environment? I'm not too sure. I haven't actually physically been to the food distribution sites. The mayor has been to one site in Brooklyn, and it was great for us, that he was there, and now more people know about the Get Food program. But all drivers are required to wear PPE. They're required to wear the protective gear, face masks, gloves, to reduce transmission in the community as they're delivering the food. And like I mentioned, yes, New York City is very diverse. We all have different dietary needs, different dietary restrictions. We have people of all different religions here as well. So we have taken into account the diverse population. And as of next week, people can actually choose in the application process whether they require halal food, kosher food, vegetarian food. They could put if they have hypertension, high blood pressure, or if they're diabetic. And so with those dietary restrictions listed in the application, then your box that comes to you will have food that is aligned with your diet. Was that it?
I think so far, I think most of the question is about that. They concerned about that, the food distribution, and then who prepared the meal. But Zeus, do we have more time for last question? I think Azi asked one question that.
Yeah, definitely.
Yep.
Yes.
Okay, so I think last question is about how's the condition going on, and is there any expertise in US predicting anything about this condition? And is there any opportunity for the second wave of this COVID-19 coming in New York City?
Yes. Okay. So, you are asking a very good question, where even the professionals are not really sure themselves. All we could do at this point as public health professionals is follow guidance. And the CDC is providing guidance at a national level. And then our governor, Governor Cuomo, who is the governor of the entire state, is providing guidance at a city level to our mayor. The mayor was in my slideshow, so he's the mayor of New York City. And really, we've taken the approach to ban major functions. So you see a lot of large gatherings have been completely canceled. So conferences, concerts, all of those types of gatherings that were happening this summer are now canceled till 2021. As I mentioned earlier, schools. So schools are closed until the fall. Universities are also doing online learning as well in New York City as well. So we are really trying to keep people at home as much as possible at this particular moment in time. And we are mandated to stay home until the 15th of May. But now we have to look at risk mitigation. And the World Health Organization has issued a guidance on reopening. And at the moment, we have to look at what parts of the city can be reopened and how are we going to do that? How can we mitigate the risk? I'll give you a specific example. If we are reopening a restaurant, one strategy that we could take is separating the tables, making sure that we have tape as you line up. So just measuring out 6 feet for people to stand 6 feet apart as they wait online to purchase their food. And when they sit down to eat their food, that they are 6 feet apart from other people in the restaurant. And so these are the steps that we may have to take once we start reopening. So we are being reassured that yes, things will get back to normal soon, but there will be a new normal for quite a while as the cure is being developed and the vaccine is being developed as well. And those things really won't be available to the public until next year. And that is an accelerated vaccine development. Vaccines usually take maybe a couple of years to make because you have to run clinical trials and you have to test as well. So right now this has been accelerated and hopefully it will be available to the public in about a year. But from a public health standpoint, we have to think about making sure that all New Yorkers, no matter of race or income or where they're living, that they have access to the vaccine.
Yep, clear.
So,
Thank you so much for the information. So,
Yeah.
Aziz, I think Charmaine answered your question already, right? Yeah.
Huh?
Okay, great. Okay,
Yes.
yeah, that was from Aziz, the question. So thank you so much, Charmaine. It's very, very insightful. We get to know
Thank you.
how New York City cope with all this situation, and I think from my country, Malaysia, we do have some similar strategy going on. It's just
Oh,
that
great.
yeah, it's good. And hopefully everything's going to be getting better soon. Getting better soon,
Yeah.
so that we have our life back again.
And how long do you have to stay home in Malaysia for?
Currently, our lockdown period extended to 12 May. 12 May,
12th of May. So around the same time, like mid-May
right?
time.
Yes.
Okay. Okay.
Yes. Yep. So
Nice.
thank you so much again.
Thank you. Thank you
Round
for
of
listening.
applause.
Thank you, guys. So I'll mute myself now.
Yeah, you can. Thank you for your proactive. Okay, so right now, let's proceed to the second session of the conference, I would say. Okay, so right now, we are going to invite Dr. Arif Sabta Aziz. Okay, so he's from Indonesia. He's a nutritionist and also lecturer in genetics and maternal and child health nutrition at the Department of Nutrition, University of Alma-Ata in Indonesia since 2019, right? So he completed his human nutrition degree from Brawijaya University in 2014 and was awarded a PhD in biomedical science from Andalus University last year. So he just I would say a fresh grad. Okay, so he has initiated the vitamin D in pregnant mothers cohort study as well as his PhD dissertation topic that aims to analyze the genetic and non-genetic risk factors of vitamin D deficiency and the effect to newborn anthropometry measurement among Minangkabau pregnant women. So it is a longitudinal study in West Sumatra, Indonesia. Through his doctoral research study, he received grants as primary investigator and from Indonesia in Ministry of Research, Technology and Higher Education, Indonesia Danon Institute Foundation. So yeah, he received grant for his research study, and the primary research focus on his study was on establishment the role of micronutrients and lifestyle in the prevention of malnutrition and pregnancy complication for improving maternal health and pregnancy outcomes, as well as investigation of gene nutrients interaction on metabolic and improved, wow, that's a lot. Okay, so and also at the same time improve maternal health related outcomes using combination of genetic, epidemiology, statistical genetics, and molecular biology. So it's very, I would say it's very nutritional science. So let's see how Aziz talk about all this information regarding this topic about this vitamin D status and its role in maternal health and pregnancy. So let's welcome Aziz
Yep.
to the floor.
Thank you, Julian, for introducing me. So good evening in Indonesia and happy Ramadan Karim for all Muslim brothers and sisters. I will share my screen. Okay. So yeah, I'm gonna talk about my research during my PhD. Like, is there any sounds?
Yeah, we can hear you.
Yeah, but there's like a background sound, like a music.
Yeah, background sounds. Can you unmute?
Yeah.
Okay.
Yeah.
Thank you. Yeah, like in this opportunity, I would like to share about my recent research during my PhD, and this title is how the evidence of vitamin D status and also the role in the maternal health and pregnancy outcome. we know that more than 1 billion people in the world have low vitamin D level, and this vitamin D deficiency prevalence is spreading around the world. And this not only in the 4 seasons countries, but also in the 2 seasons countries like us in Indonesia and in the Southeast Asian regions that have along a much abundant sunlight exposure. And we know in the Indonesia, like 90% of pregnant women have vitamin D deficiency. And also my research found that in the 2017, that from 160 pregnant women, that more than 60% have vitamin D deficiency. And most people didn't aware that they had vitamin D deficiency status, giving rise to this concern that people mostly didn't care about their adequacy of vitamin D level. And what is the vitamin D and what is the beneficial of vitamin D throughout our health? Vitamin D is an extremely important that has a powerful effect to our several systems throughout our body. And vitamin D, or we can say a sunshine vitamin, because vitamin D 90% coming from a sunlight exposure, and 10% we can afford vitamin D from our dietary intake. And vitamin D functions like hormones like calcitriol. That's why vitamin D oftenly known as it's not like vitamin D, but in the our metabolism, vitamin D has active vitamin D types that have functions as hormone in our body that can regulate the calciums, homeostasis, and other skeletal functions in our body. And every single cell in your body has vitamin D receptor. This is the interesting point about vitamin D. We can find a vitamin D receptor almost in all of tissues and cells in our body. And vitamin D receptor found from most tissues and organs of the body, and specifically during the pregnancy, they involve in charge of a decidual development and placental developments, and also in the immune cell, that in the implementations process, it's play a huge role in the pregnancy. And this is why vitamin D deficiency, we can found this deficiency in all age groups, because vitamin D has a particular functions from the gametosis, during pregnancy, in infant health, adult health, and elderly health. Vitamin D primary factors we can afford from the sun, diet, and supplements, and this modifying factor like our skin pigmentations, clothing, sunscreen, pollution, season. It's all the modifying factor that can determine our vitamin D status. And that's why, based on these informations, we would like to have a study that associates the lifestyle, genetics, and also is there any associations between vitamin D and the pregnancy outcomes. And this is our aims of study. That the first, we want to look the risk factors of vitamin D status pregnant woman in the early gestation period in the first trimester, and then we want to know the relationship between the genes polymorphism that working in the vitamin D synthesis and metabolism, and also we want to know the relationship between GRS. GRS is genetic risk score, that we combine all the score from the people who have genetic variations among the genes that we working on it. And then the last, we want to know about the relationship between maternal vitamin D status and newborn anthropometry, and specifically in the population of West Sumatra, Indonesia. And we had a cohort study. This is like a pilot study with not too big sample size, that we have only 230, and we still have to do this kind of cohort study with larger samples or subjects in the future. And we conduct observational prospective cohort study that we measure vitamin D status in the first and third trimester of pregnancy, and we using the PCR to assessing the genetic variations from the pregnant mothers. And also we already did this study for 1 year in during to 2017 to 2018. And this is how the vitamin D related genes polymorphism affect vitamin D level. That's why we look the genetic and non-genetic factors, because when we have various genetic variations in our body, that we can have a risk factor that we would like to have lower vitamin D level, because we have some mutations in our genes that working on vitamin D metabolism and synthesis. So in the bold word, this is the genes that involved in the enzyme that working in the synthesis and metabolism. In the ups there, this is a genes that working in the synthesis process of vitamin D, because we know vitamin D can be synthesized by our body after our skin get exposed from the solar UVB exposure. And in this study, we want to combine like two perspectives of the research. That first one is genetic perspective, and the second one is public health perspective. That we did this perspective into our analysis, and it comes to the genetic epidemiology, that the joint action of research from genetic and the environmental factor, that we want to know how the exactly association between genetic and the epidemiological factor through the environmental factors like our lifestyle, our diet, and etc. And the result from this study, the prevalence of maternal vitamin D status during pregnancy in our study, in the first trimester, we know most women have a lot of deficiency vitamin D status, that 47.8% and 35.6%, they all in the deficiency and insufficiency vitamin D status. But after the growing of the pregnancy and the trimester going up, and the third trimester, we again measure the vitamin D status for the pregnant women, and we came with the difference, a significant difference prevalence, that most in the women in the first trimester have deficiency, but in the third trimester they have more in the sufficiency status, because when we are in the first trimester, we still have some nausea, vomitings, and some dietary restrictions, because uncomfortably to eat in the first gestation period. But after we have a lot of antenatal care and a lot of advice from the healthcare professionals, so we have more than a supplemental like micronutrient, and later on there we have a better of vitamin D status and a better the dietary pattern of the pregnant mothers. So what are the risk factors of vitamin D deficiency? From our first aims of the study, that we want to know what is the associated risk factor of vitamin D in the early gestations. We found that mothers who doesn't work or staying in home or being a housewife, it's have a lot of risk factors to become a vitamin D deficiency. And also pregnant mothers that less than 1 hour activity outside have like 4 times fold increased risk of vitamin D deficiency. And also pregnant mothers that not consume supplement before pregnancy, that they have like 4-fold increased risk of vitamin D deficiency status. And this is the result about the association between our genetic risk factors with a vitamin D level. And then we did some calculations in the genetic base, and we try to find the association between unweighted and weighted odd ratio genetic disorder. That is, we sum all the genetic variations from the mothers. We have like 6 SNPs from the genes that working in the vitamin D synthesis and vitamin D metabolism, so that we sum up and combine all the genetic variation, and we give it a score. So people who have, or women who have more allele risk score or have more genetic variations, they have more likely have a vitamin D deficiency. We see in the graph that people who have allele score more than equal to 6 have lower vitamin D level than women with allele score lower to 6 genetic risk score. And also we can see not only in the all vitamin D genetic variations score, but also in the vitamin D gene that working in the synthesis process, and vitamin D that working in the metabolism process. And also we found the interactions between genetic risk score and 25 hydroxy vitamin D. This is the form of vitamin D3 in our bloodstream, and with the newborn anthropometry, specifically in the head circumference. There is interactions that women with have the small head circumference baby, if they have more than 6 risk allele or more than genetic variation, they tend to have more likely have a lower vitamin D status than in the women with a normal head circumference baby. They will still have a higher vitamin D levels. So I want to make some discussion or fruitful discussion after this, that during the epidemics, pandemics in the COVID-19, that vitamin D has a rise concern that they can improve our immune system, our immune cells. That's we need to get exposure more time under the sunlight exposure under UVB, and we need to make looking a dietary pattern with some specifically foods in the oily fish or cod liver oils, and etc. This is some of rising topic in this situation, and we can discussion this topic later on. And based on our study, we have still some research limitation, that and then in the number of the sample is still small, and it doesn't look at overall determinants of vitamin D status, like skin pigmentations, parathyroid hormone. We don't include the seasons in our analysis, culture, and frequency of supplemental during pregnancy. And vitamin D level measurement instruments still do not use in the gold standard like LCMS. We did the measurement with ELISA, that we still have a high of bias, and only analyze SNPs related to vitamin D levels based on the genome-wide association study. That we have a significant association, but the genome-wide association study more having in the European and Middle East countries. And the conclusions, we have been found the risk factor of vitamin D status in the specifically Minangkabau pregnant women in the early gestation, that a mother who do not work or as a housewife, outdoor activity, or the length of sun exposure less than 1 hour per day, and do not take supplements or multivitamins before pregnancy. So that's why that we need to prepare our preconception period before getting pregnancy. And there is a relationship between the polymorphism of specific genes that we're looking for, and then there is a relationship between the genetic disorder and vitamin D levels during a pregnancy in pregnant women. So it's answer the question that of genetic factors have a due significant association with a vitamin D level, specifically in Indonesian pregnant women, in the Minangkabau pregnant women in West Sumatra. And the last there is no relationship between maternal vitamin D status during pregnancy with anthropometry of newborns in our population, but the interaction still found between a GRS and vitamin D levels in heart circumference of the newborn. Okay, thank you all for your attention, and hopefully we can have a discussion after this.
Yeah, thank you, Aji. Thank you so much for the interesting information. It's actually a lot. Yeah, it's a very big study. It's a core
Yes.
study, right? How long was your core study? Sorry, just now I might miss out the information.
Okay, like from the preparation, I totally have 2 years to conduct
okay.
this study.
Okay. From mother's first trimester until newborn.
Yeah, until newborn is like 1 year of following process.
Okay. All right. So is there any question from the floor?
Okay. I volunteer to ask question again. Mela.
Oh, yeah.
Okay.
Hello,
Aji.
Mela.
Hi, Aji. Because you just mentioned about the increasing interest in vitamin D to enhance immunity. So a colleague of mine were asked by a friend of hers. Okay, the friend of hers is a health worker, and they were asked by a doctor to take in vitamin D supplements to boost their immune system. So, is there any basis for that?
Yeah, like we still have a debatable or conflicting the result of the vitamin D research, because we don't know how exactly the regulation if we want to have a high or a sufficient vitamin D status, and then come up the supplementation is the alternative that we can do in these situations. And we in Indonesia we have like advice to consume at least 400 international unit or 15 micrograms of vitamin D per day, and sometimes the supplement factorial provide like maybe thousands international unit or until 20,000 of international unit of vitamin D per capsule. So this is like still in the research and still in the debatable of this kind of supplementations interventions. Yeah.
Okay, thank you.
Okay. So, is there any other questions before I ask my question? It's okay. Let me ask my question first. So, Dr. Aziz, so you in your study you actually found genetic risk score association between genetic risk score with vitamin D level of pregnant women, right? So how can we apply this in our future vitamin D level of our pregnant women? How can we apply this knowledge, like association between genetic risk score and also with vitamin D? How can we apply this in future intervention?
This is the future of personalized nutrition therapy that we want to do it in the future, but it's still in the like pilot study, so we still have to require further research around the world or in Indonesia, because we have a very different places, and we have so many cultural. So this is the different ethnics could have a difference in inheritance and the genetic patterns. So this is still in the early of research, and we need to confirm this finding with a lot of samples, subjects. Yeah, but in the future of personalized nutrition, this is the one of the finding that we can do or afford in the future.
Okay. So that's that you mean by what you mean is that in future when personalized nutrition is a norm, so this research is going to support the application of that personalized nutrition services, right? For example.
Yeah, right.
Okay. Yeah. Okay. I understand. Thank you so much for the information.
Can I ask a quick question?
Yeah, Charmaine,
Yes,
go on.
Like a question statement thing. Yeah, I was just like on the back of what you're saying about the genetic variants, which I find very interesting because I know there was another research study where you know, they were stating that people of darker skin actually have an SPF, like they have a natural SPF in their skin up to maybe about 15 SPF. So it's like we have this natural sun blocker that's in the melanin. And so even if you go outside for 15 minutes, as opposed to someone with lighter skin, you're not really absorbing the vitamin D. Anyway, so really certain people should be taking supplements anyway, right? So because whether they go outside or not, they would have to be outside for a very long time to benefit.
Yeah, I agree with your chairman. Like the skin pigmentation so varies, and the melanin that the make our become black or white or pale. So the darker skin we have, so we need more time to get sunlight exposure to absorb of vitamin D.
Yes.
Yeah.
Thank you.
Yeah.
Thank you so much, Charmaine, about the extra information for the floor. I think we have one more question here from Preeti. Can you see that, Aziz?
Yep.
Yeah, she asked, can you please suggest some ways to maximize the vitamin D intake during this pandemic? Yeah, because we can't go out to have sunlight, exposed to sunlight.
Yeah, actually we can still have go out, like doing some outdoor activity, but if we have some a gardens area in our house, and we can still have can do some workouts outdoors, but we can have vitamin D from the dietary intake as well. But like in the first presentation I said, dietary intake can also have only 10% of the vitamin D, but the 90% we can absorb vitamin D is coming from sunlight exposure. This is a natural way that the vitamin D have more to synthesize from the sunlight exposure than a dietary intake. That's why if we talking about vitamin D, we cannot away from the supplementations. Like the chairman said, even though we have outside activities and then we have some proper sunlight exposure time, but some people with a darker skin, with the some specific where they stay in the in the latitude, and the more we near the equator, yeah, where we live near the equator, we have more sunlight exposure because we have abundance of sunlight exposure. So we maybe not too compulsory to take a vitamin D supplement, but still there are some consideration in some kind of condition that we need to consider. Yeah. So the vitamin D intake, we can oftenly eat fish, oily fish, and mushrooms, and also in the vitamin D has high in the eggs and also high in the some dairy food product, because some dairy food product has been fortified with a vitamin D as well.
Okay. Yeah, thank you so much, Aziz. So any more question? Oh wait, I think Shoma has another question. I think she asked, to what extent can the sun help? To what extent can the sun help? Can you see that?
Yep.
On
To
top,
what
yeah.
extent can the sun help?
Yeah, I
What's
think
the
that's the last
meaning?
question.
What extent can the sun help?
That she means how much sun can help the vitamin D synthesis in our body.
Okay.
Do you
Yeah.
have any? Yeah.
Talking about the sunlight, so we still have a various number of the people who living in the sum of considerations, right? Maybe if in Indonesia we have a sunlight UVB window like in the 8 p.m. until in the 3 p.m. because in these times we will can face sunlight, but when we want to make sunbathing like in the 7 or 8 or 9 a.m. we need more time to get exposed by sunlight. But if we want to make sunbathing in the 10 to 12 uh, 10 to 12 and we only spend like 5 to 10 minutes, that's enough because the height of sunlight above us then can determine like how long we still in the sunlight exposure. But it's different country, different area will be different.
So okay, I think in a more layman term way is that how important how is the rank of different vitamin D sources? Like the first one should be sunlight, the second one should be dietary intake, and the third one should be supplementation, or
yeah,
how is the rank there?
How is the range?
Yeah, like how should we rank the importance of all these elements to get enough vitamin D?
Firstly, we have to make sure that we got a sunlight exposure first, and then from the dietary intake from our foods, and the last from the supplementations.
Okay, understand. Yeah, so okay, we don't have any more questions coming in. Thank you so much, Dr. Aziz. Thank you again for the insightful research and also information. It's very interesting. So we are going to end our session here today. It's finally come to an end, and but everyone don't leave. We are going to have another session on 9th of May 2020, same global time. Okay, so you can always follow iYouLead Twitter to for the updates, okay, for the updates on the and also the presentation if you are interested to get that presentation slides. All right, so yeah, those slides will be on our Twitter account. You can always access that slides on the Twitter. So that's it. Thank you. Yeah.
Quick question. Are you doing it? So the date today is the 25th, and you said the next one's on the 9th.
Yeah.
So it's like a bi-weekly session. I mean,
yes, yeah, like every 2 weeks. Yeah,
every 2 week, bi-weekly. Okay, okay. So that's what it will be for now, bi-weekly.
Yeah. So we have 4 sessions in this series. So we are on the second session, and the third
great.
9th of May. And we have 2 speakers for that, but we are still hoping to get one to make it more, representative from other countries, because currently the 2 speakers come from Indonesia. So we would want to have speakers from other countries or other territories, like, for example, Singapore. Or we can have another one from the Philippines. Hello, Mela.
It's your time, Mela.
Yeah.
I know.
Yeah, so we are hoping to, accommodate, because that would be the last session, I think, that we will have speakers from our members, because on the last session on the 23rd of May, we are trying to invite a very important person.
Who is that?
Ooh.
And any one of our professor?
Belum what?
I am trying to communicate with Dr. Lawrence Haddad, who
Oh,
is
wow.
the director of
He's
Who was-
what?
he is the current executive director of the Global Alliance for Improved Nutrition.
Gain.
Oh,
is quite-
Gain. Oh, that would be great. Yeah.
Yeah, so he's
Yeah.
quite a big personality in the food and nutrition sector, and
Yeah.
he is supporting young nutrition leaders. One of his works is to support young food and nutrition leaders. So
Where is he based, Jules?
He is based currently in the UK, in London.
Okay.
Yeah, so I was able to have a very quick chat with him just to inform him that we are planning to invite him, and
Right.
he's quite excited. But now I'm currently writing like a formal invitation letter and trying to send it to him next week.
Oh,
So-
that will be good.
But he already
Exciting.
he already knows the date. So we are reserving the last session for him. A very special session for everyone. So so for the third session, we are hoping to get another one speaker from a different country, hopefully Philippines. I'm looking at Mela because I'm so interested with her research.
Yeah, come on, Nella.
Yeah.
Wow, I'm on the spot now.
Yeah, maybe just the quantitative part of your research, but really, if you're ready, just inform us. And
Okay, it is May 9, right? May 9.
yes, and it's on the 9th of May, which is 2 weeks from now. Yeah.
I'll inform you.
Yeah, just let me know.
Okay.
Okay. And
Okay,
if
Mela.
there's any
Ang
question,
kasha. Picture.
yeah, you should take. I'll stop sharing this slide. Okay, so we can have a photo.
Yeah, let's take a photo.
Have a photo with my giraffe.
Oh my god.
Wait, who is going to take the photo? Wait.
I think Alice.
Alice, is it?
Oh, all right. Okay.
I'm going to do the screen capture,
Stop.
is it? But not
Yeah.
everyone is turning on their camera. It seems quite.
Okay.
So everyone can.
Yeah, can
turn
you
on the
guys all
camera.
turn on your camera?
Andi Kurniawan, Desti Arvera.
Hi, Kai. Karen.
Let's see.
Can I do? Oh, wow.
Hello from
Oh,
Sydney.
okay.
Okay.
That was
Hey,
wonderful.
everyone.
Thanks, Charms, and
Hi,
Hello, Karen.
thanks,
Oh,
Charms and Aziz. That was so good.
Thank
Please share your
you.
slides later.
Yes, I gave my slide. Jules, you have the slides, right?
Yes, I will be sharing it in the next days.
Or Charms. Sun is up in your place.
It's good. I'm like, there's nothing I can
Oh my god.
Vitamin D,
You're
Vitamin
already
D.
sunbathing, right?
That's the vitamin D presentation.
Yeah, you are getting vitamin D, Charmaine.
Quick response.
So good.
Alice, are you ready to take the snap?
I already do the screen capture, but
Oh,
everyone is.
already. Okay.
Okay, you guys want to take one again? Okay, please look at the camera.
Okay.
Okay, I will
Let's do it. Let's do it.
1, 2.
Maybe with thumbs up.
Okay, thumbs up.
Thumbs up.
Okay, please hold on for a second because I need to switch to another screen.
Thank you.
My
Otherwise-
giraffe is getting tired already.
Okay, 1,
Yeah.
2, 3. Okay, I think it's fine.
Thank you,
Thank you.
Alice.
Thank you, Alice.
Thank you so
Thank you,
much.
everybody.
very
Thank you,
much,
Sam.
everyone.
Thank you, Aji. Thank you,
Bye.
Joe.
Everyone, see you online, May.
Stay
have
safe,
some-
everyone.
So we have Mela to
Thank you, everyone.
session.
You mean the other speaker, Anta?
Yeah.
The other?
Yeah.
Like you.
Yeah, I thought to Jules because
But it's
Thanks,
7
Anta.
minutes, you know. I never finish 7 minutes in Bali.
You can do it.
That's so
10
much
minutes is
pressure.
tough.
yeah.
Yeah, I know.
Yeah, we were in the same
Well,
session, right?
Do it.
Yeah, the three of us. Oh no, 4K.
Or
Yeah, yeah,
we can
including
invite one
Charmaine.
from Malaysia, I think.
Like
Yeah.
Jolene.
Yeah. So we have 4 speakers.
Yes, I can hear you.
Jolene, come on.
Jolly
Who's the
Networks
other-
meeting again.
The other one from Malaysia, the one who won an award together with
Yeah.
Cynthia.
Kohong, yes. Yeah, Jules, your
Jules,
your roommate. Your roommate. You
He's
should.
very, very resistant.